Then the application of, I shouldn't have mentioned here Prilox, then the application of lignocaine 5%, which is usually not available. The patch, very frequently it is not available. So what is available with us is a combination of lignocaine with prilocaine. So an application of Prilox or lignocaine with prilocaine would have helped in this patient. Now, once this has been done, my next query comes, this patient got resolved. What if this patient wouldn't have got resolved even after a month or after 3 weeks of the chronic pain or gabapentinoids and TCADs also? So taking in view that basically the involvement of this patient was in the division of C2, 3, 4, I would have had 4 options. One would have been, few of the pain physicians, all of us are practicing it. Few of us would have thought about giving a stellate ganglion block to this patient. Few of us would have thought of giving this patient a superficial cervical plexus block. Few of us would have thought of cervical epidural, and some would have thought of paravertebral blocks. Now, what is important at this particular point is 2 things. First, controlling the pain. That is our prime objective. The second is avoiding the conversion of acute or subacute herpes pain into a condition which is more devastating, which is post-herpetic neuralgia. So let's see what literature has to say about all these 4 kinds of blocks in terms of controlling them from converting this disease into a chronic phase. So corticosteroids, antidepressants, anticonvulsants, antiviral agents, and vaccination, they have been proposed to prevent PHN. This is a systematic review meta-analysis. However, according to a recently published systematic review meta-analysis, the effectiveness of these strategies towards preventing PHN is insufficient. The last line being written is only in the immunocompetent people who have got their vaccination done, if their age is about above 50%, there is a possibility that PHN would be avoided. Little bit more into this particular article, if I say, stellate ganglion block and a single epidural injection did not achieve positive outcomes. Although somatic blocks, which includes paravertebral and a continuous epidural block, they are recommended to prevent PHN. So at any point of time, if at all we get this kind of a patient, which has just overcome the acute phase, is in the subacute phase, and we want to control the PHN being developed in this patient, so either we have to go for a somatic block, and that too not a single shot somatic block. You have to continuously repeat that somatic block at an interval of about 3 to 7 days. Along with that, paravertebral and epidural blocks are considered a continuous epidural block. These are recommended to prevent getting acute herpes zoster getting converted into PHN. So with this, I end my first case where we have seen the management of acute, we have seen the management of subacute herpes, and we have seen into the literature what prevents conversion of acute or subacute into a PHN. Now let's move on to a second case. So my second case, which came to the picture is not of that patient. I just forgot to click a picture of that patient, but this was a 50-year-old lady. She developed herpes zoster maculopapular rashes 2 weeks back. Now she was in the subacute phase in the left upper limb. The lesions have started to dry. She has already finished her course of antivirals. She started her gabapentinoids 3 days back, but still she was having an unbearable burning pain. So what should be my management at this particular point of time when gabapentinoids have just started and the patient is still in severe burning pain? So in this case, it was relatively, I would say, my first bet for a left upper arm was giving a sympathetic block to this patient, and that too not a single sympathetic block, but multiple visits, multiple sittings of sympathetic blocks. And in that terms, I had performed stellate ganglion block in this patient. So I posted this case in the OT, gave 2 sittings of sympathetic block. So I had put my probe at the thyroid cartilage. I saw the V-shaped structure of the thyroid cartilage. This was the thyroid cartilage. Then I moved my probe a little bit down to the cricoid cartilage so that it starts appearing circular. Then from cricoid cartilage, I move my probe laterally so that I start seeing the thyroid gland. Further lateral, I go, I see this uh, sheath of carotid, below which I will see the longus coli muscle. So this was my picture where this was the thyroid. These two were the tubercles of, so this was the vertebral body and these were the tubercles. So when I shifted my probe laterally, I also have a video of it. Shashank, should I play a video? It is of 2 to 3 minutes, or do you think I will overshoot the time and so I should play it later on if I have time?
You can play. It would be more relevant if it's played right now.
Okay. So with the linear probe, I'll try to fasten it up. Always, while performing stellate ganglion block, you should have your airway gadgets ready, your airway crash cart ready. I was prepared with the local anesthetic. I also had steroid in it. So I was using dexamethasone with it. With the patient in the sniffing position. Now, this particular ultrasound video was of some other patient, but then this is just to show how do we perform stellate ganglion through ultrasound in a sniffing position with pillow below the shoulders. You need to take care of the ergonomics where you are standing with the trolley, the patient, and then the ultrasound machine in front of you so that you don't have to recurrently move behind to see the patient with an assistant. So now here I have placed my probe on the thyroid cartilage and then I've started to move down. Now I see a circular structure. From this circular structure, I start moving laterally. So I here see the thyroid gland. I see the carotid sheath. So this is the thyroid gland. This is the tubercle. This is the transverse process. This is the longus coli muscle. The brown color is the longus coli muscle, and this is the medial scalenii muscle. So this was the anterior tubercle and this was the posterior tubercle, and this particular dark shadow in between the two of them is the C6, which you can see it is dipping down, it is coming up. And because these are two tubercles, then it has to be C6. And as it is, because I have come laterally from the cricoid cartilage, so this was a C6 level. And you can see this beautiful cervical nerve root coming out between the two tubercles. But I need not give block at C6 because the pain was in the arm, so I had to go a level below. So from here, when I am seeing the two tubercles, I'll move my probe down so as to reach to the C7 process. So from this transverse process, now there was a middle phase where no transverse process was there. Again, a C7 transverse process has come up with a tubercle. And here you can see the vertebral artery coming out, and there is only a posterior tubercle. At C7 level, you will not see two tubercles. So this was the vertebral artery. And once vertebral artery is there, you need to be really careful and you are very sure now that you are at the C7 level. Lateral to medial, I'm injecting. I'm putting down my needle from lateral to medial. And these are the two sheets. You can see a small gap in between the two. So this is exactly the location where I should put my needle ideally. This has gone slightly more down. I think I should have been slightly more up. And after this, if you want the drug to spill down, you need to Shashank, my face is not coming on this video so that I can tell them how to compress it. Mm.
It's visible. Your screen is also shared and your video is also here.
And am I being shown on
Yes,
the
yes, yes, ma'am. You are already shown.
camera shows me?
Yes, ma'am.
Okay. So once you give this block at C7, you need to compress from your hand near your angle of jaw so that the drug it spills down, it doesn't go up. The Horner syndrome showing that the drug has still gone up and the symptoms of the patient could be seen. So we had given 2 sittings to this patient at a gap of 1 to 2 weeks. After the first stellate ganglion, the NRS reduced by 50%. After the second, it reduced by 70 to 80%. We asked her to continue on pregabalin and tramadol on need basis. And this patient later on did not complain of pain. And also, I'm hopeful that she wouldn't have developed a PHN later on. But then I did not have a complaint after that. So this was how you control a subacute getting converted into a PHN. Now I come to a third case where a 56-year-old lady, herpes zoster erupted 4 weeks back. So still she is in that subacute phase. It was in the T11-12L1 dermatome. She took her course of antivirals, oral analgesics. Currently, she was taking pregabalin. The lesions are absolutely dry. The NRS was 80 to 100 despite oral analgesics. In terms of comorbidities, now this was the lower thoracolumbar division. In terms of comorbidity, she had a history of hypertension. She was a case of old CVA, CKD, and she also had an old case of pulmonary tuberculosis. So despite giving oral medications, I added some more topical medications to give to her. So lignocaine plus prilocaine for topical application. Now there is one particular ointment which was told to me by one of my good PDAF student, PDCC student, just missing out his name. So he told me to try this particular cream with a combination of gabapentin, ketoprofen, capsaicin, and methyl salicylate. And since then till now, I do not find it anywhere in the shops. It is always only through online that I get this medication. I don't know how to get hold of this particular antibiotic, but all the patients to whom I have prescribed Instasense, they have had for a very difficult pain also Instasense works wonderfully because it has probably all the components what is actually required for a topical medication what has been approved. So we started this lady on gabapentin and we added TCADs also. After a week of follow-up, there was no significant relief despite topical, despite giving her supplements also. So despite giving her tapentadol also. So we performed because it was a lower thoracic and lumbar region. So we performed TFESI at L1, giving LA with dexamethasone. There was a relief of about 40% for 1 to 2 days, but then it went on to the same intensity. Now, as I have already discussed in that systematic review, for a subacute phase, what works best is epidural. So we had admitted this female. We started her on an epidural infusion of 0.1% ropivacaine with fentanyl. And this is my resident. He's Dr. Suresh. Now he has passed. And then he put in an epidural catheter and uh, later on we fixed it. And so in this first figure, you can see this catheter coming out. Then we fixed it and we kept the patient with us, admitted in the ward for 5 days. After 2 days, the NRS came down by about 30%. So we discussed, we increased the concentration of fentanyl as well as ropivacaine. NRS after 5 days, it came down to 30. So she was very happy. She was old lady and there was her daughter-in-law and son, everybody in the ward, and they were very happy. And so we discharged her on pregabalin, tramadol, on oral analgesics, continuing them. But on fifth day, we discharged. After 1 month of follow-up, still the patient had NRS of 40. So a continuous epidural, we were hopeful that probably this should not get converted. But then despite that, the NRS was 40. So we planned a DRG T11-12 PRF for this lady. And after performing DRG at 11-12, the patient had 100% relief at 1 month follow-up. And after that, she was lost lost to follow-up. So I don't know what happened after that, but very rarely do we see 100% relief in these patients, and I was lucky enough. So this was the same case where we had done it at T11 and 12. And this is me performing the DRG for the patient. And after that, the patient did have relief. Now, we are done with the first 2, 3 kinds of cases where we have acute, we have subacute, we have a later phase of subacute. Now we are moving on to the chronic PHN part. 74-year-old male, very difficult. PHN in the T11, 12, L1 lesion. So the lesion was more than 6 months. We don't know if he took antivirals or not because he came from outside. He did not know either. He did not have relief on weak opioids. He was a controlled hypertensive. His DSM was very high. He was very anxious. We did take care of, sorry for the last line. So we did take care of his DSM scores and his pain. And then again, I started a combination of topical medications. Once I give topical medication, it has to be every 3 hourly, alternately, Instasense and lignocaine with Frilox. So alternately, after every 3 hours, they are applying one or the either. Then I started the patient on gabapentinoids and TCADs. I gave him supplements and tapentadol. So obviously, when he came, he did not have a significant relief. So we posted him for T11, 12 intercostal, which gave him relief of 50% for just one day. So we were trying to take care of the somatic component. But then after getting 50% relief, when we performed RFA in this patient, a pulsed RFA, there was insignificant relief. The next step for me was not actually to directly jump onto DRG, but then I admitted this patient because it seemed to me that this patient is going towards a refractory case. So we admitted him. We started him with ketamine and lignocaine infusion. We had planned to give him this whole drug within 4 hours, but immediately after 1 hour, his BP shooted up. He became very agitated. We had to stop it. And then we had to discharge him because he was very upset. Later on, he again came back to the OPD because he knew that we were trying genuinely for managing his pain. So then we planned him for T11, 12, L1, DRG diagnostic followed by PRF. So we put in 3 needles at 3 different levels. Upon T12 simulation, so L1 DRG, we got the stimulation, we performed it, and we were very happy. And he said that, yes, I'm feeling the sensation in the same area. As soon as we gave a T12 stimulation, this patient developed vasovagal because the stimulation was so intense probably that he developed a vasovagal. We had to abandon that procedure. But despite L1 DRG being done and the DRG being performed only at one level, the patient had 50% relief even after 6 or 7 months of follow-up. So we were happy with the way DRG worked out, at least for us. And again, we had planned him for a T11, 12 DRG because we couldn't do it on the first setting. So after 6 or 7 months, we did do it. But till date, he is a difficult case and we were able to contain his pain only till about 50%. So this is about that particular case of PHN. Next case, this is an interesting case. In all the cases, you can see different kind of management going on because it is always a patient-centric approach rather than what we know we have to do that. A 63-year-old female, known case of myeloma, CKD on ecosprin, herpes zoster happening about 6 months back or maybe slightly more. NRS 70 to 90, so she was a case of PHN on gabapentinoids and opioids since 4 to 5 months. Clinical examination showed healed lesions in the V1 distribution. So it was in the supraorbital trochlear region that we could see the lesions being there. The MRI was insignificant because I had to actually see whether it is actually the trigeminal neuralgia part which is bothering her or is it the herpes part which is bothering her. There was no neurovascular abutting, but then I was not willing to do a trigeminal in this patient because she was already taking ecosprin. The DN4 was very high, it was burning, and she had a strong sleep deficit. The DSM scores, the DSM scores were also very high. So a supraorbital and a supratrochlear nerve PRF was performed in this case. So after all the medical management, after all the 4 or 5 medical managements that we could give, now because it is the face and we know that sympatholytics cannot be given for a PHN. I'll show you the chart where it shows that for chronic PHN, sympatholytics are not indicated. So trigeminal, ganglion, Gasserian ganglion, supraorbital, supratrochlear PRF can be given to this patient, which was given, but unfortunately the patient did not have a good relief. And this is a literature saying that the ganglion, Gasserian ganglion, supraorbital trochlear may work for these kinds of patients. It has worked for other patients. Now, what next? If that is not working, now what remains in my hand was I had explained to that patient's attendant that the last thing that I can help your mother with is botulinum toxin. So I had attended ISPCCon 2024, where Dr. Ruchi from Amritsar, she explained how botulinum is being used aggressively for management of refractory peripheral neuropathic pain. And so I spoke with her, and so I gave from this particular part of the eyebrow till the area where she had pain, about 25 to 30 units I had given. I prepared 1 unit per zero point 0.1 ml, and I injected it at about 20-25 spots. I had already applied Trilox, and then subcutaneously I had given botulinum till the head. After this, she had 30 to 40% relief. She was an absolutely refractory case. She had 40% relief for a good 3 to 4 months time, after which they were happy, but then they were not willing for a repeat botulinum. So mm, this article has been published on 16th January 2026. So it's been just about 8 days back. And this is a systematic review saying that yes, botulinum does work in peripheral neuropathic pain, mainly for diabetic peripheral neuropathy or trigeminal, but it will also work for PHN and central pain. What it says is for post-herpetic neuralgia, you have to give subcutaneous injections. How does it work? It is not muscle relaxation. It is neurogenic inflammation and alteration of the peripheral sensation. And this is a small video of 10 to 15 seconds. I have taken permission of Dr. Ruchi of showing you this video of how to perform a botulinum subcutaneous in a patient of neuropathic pain. So she will tell you that you have to make these points about 1 centimeter away from each other so that a bleb is formed.
But it's covering almost 1 centimeter around that area.
So that is how subcutaneously you have to give botulinum. And botulinum has had its efficacy, and so it is particularly helpful in the phenotype when there is allodynia. Again, all these studies showing that botulinum can be tried for refractory peripheral neuropathic pain, not responding to other, to be given in the orofacial region in 25 to 100 units in small aliquots subcutaneously. So these are all the 5-6 cases which I was able to manage. A very difficult case, which still till date I have not been able to manage, is a 100 kg lady. Came to the OPD. She had herpes zoster 15 years back. Pharmacological management had failed. There was an unfortunate event in the family. Her DSM score was not even 15. It was something like 2021. Central sensitization developed in that patient. By the time she came to me, she already had a distribution between the herpes was in 5-6 region, but after central sensitization, the pain was from T3 to T8. Multiple epidurals, intercostal, everything was tried on this patient. During one of the intercostals, the patient also landed into pleural shock. But then in this patient, I also presented a paper in the Neurostimulation Society where I said that in this particular patient, when nothing was working, I did not have the option of giving her a PNS or a SCS. So a TENS machine, this particular TENS machine was used. It is a case of 2 patients. I did not have the photograph of it. So here is it. It's a 15-year-old lady with T3 to T8 central sensitization. A portable TENS was given to this patient. Now, what was beautiful about this case was for 1 year, in this portable TENS machine, you can increase the milliamperes from 4 milliamperes to 15 milliamperes. When she came to me for the first time, when I had given her a trial and I asked her to buy this portable TENS, she began with 4. By the end of 1 year, she told me till now the pain was getting controlled, and she had moved up from 4 milliamperes to the maximum 10 or 15 milliamperes. But now it was not working. So SCS actually remains my only choice. So it is basically that even a TENS machine may help. in terms of neuro. So I've had few more experiences related to stillets for the faces or for lower limbs, which have been successful. One important thing is with this zoster vaccine coming up, they say that the incidence of PHN is likely to go down. In the immunocomponent, definitely the incidence will go down by 88%. And in the immunocompromised also, the PHN incidence is bound to decrease by, so probably our guest can tell us how good is this zoster vaccine, because it was asked in one of our PDAF exams by an expert that have you seen that there has been a fall in the incidence of PHN after giving zoster vaccine. So yes, it might help. At least the studies have been done in the Western world. So this is based upon all the European, Canadian, French, the world over guidelines. This is a summary of what works for a patient of herpes. Gabapentinoids, a big yes. TCADs, yes. Tramadol and tapentadol, yes. NMDA antagonist, which we tried using it in one patient, it may or may not work. A lignocaine, capsaicin, and a diclofenac, which actually is there in my cream. So all that is, it does work. Botulinum toxin may or may not work, but with this systematic analysis just coming about 8 days back, I think it may work. Sympathetic block in PHN won't work. In acute, multiple sittings, it will work. Similarly, epidural will not work for PHN, it will work for herpes zoster acute phase. Intercostal PRF, yes. Thoracic, it will work. It may work. And then DRG may also work. So according to this, I have presented various different cases, but different modalities have been tried. But do all our patients actually gain a benefit after pharmacological management? So the same size does not fit all. So it's a big no. So what happened in 2008 to 2017? Nature, Lancet, Neuron, Review, all these major journals, they when I was reading through the neuropathic pain, they all came up with this particular mechanism based therapy or a phenotype based therapy. All these big journals are now coming down to not managing patients by their etiology, but managing them by the phenotypic character that they present. Because neuropathic pain can have different kind of characters. So a pain phenotype is basically the kind of fingerprinting that you have. It can be a burning pain, it can be a lancinating pain, electrifying pain, numb pain, negative pain, positive pain, allodynia, hyperalgesia, hypoalgesia, variable kind of pain. So we need to actually see what the pain phenotype of that patient is. We need to classify it based upon the spontaneous, the negative and the positive symptoms. And then it says for a spontaneous pain like uh, a tingling or a tingling pain, something like that, a TCAD or SNRI will work good. For allodynia, gabapentinoids will and sodium channel blockers would work good. And for negative symptoms where there is hypoalgesia or numbness, gabapentinoids and TENS and CBT will work good. So a post-herpetic neuralgia will most of the times have a hyperalgesic component and a thermal hyperalgesia. And so you can see the phenotypic character responding to pregabalin because it has a mechanical and thermal hyperalgesia. Pregabalin usually responds to this particular phenotype. And it has a sensory loss also sometimes. And so maybe TENS may work in the negative pain. So my take-home message is neuropathic pain management, it cannot be individualized. Every case is different. Every phenotype is different. Every character is different. And so we have to manage them differently. Thank you.
Thank you so much, ma'am, for delivering such an excellent talk, covering all the things, be it evidence-based, be it the classification, the various treatment modalities from pharmacological to intervention. Thank you so much, ma'am. Now I would request Shivani Rastogi, ma'am, to take forward the discussion.
Thank you, Chetna, for explaining so wide variety of cases from conservative to intervention pain management. What actually you do for the acute pain in this first patient, which you were saying your relative? I think your guest is with us in the panel. Dr.
Yeah.
Vaishya Tandon is there.
Yes, good evening.
Could you express the management in acute patients?
Yeah, thanks for invitation.
Sir,
And
the
Dr. Chetna,
dermatologist
yeah, I'm a
in
dermatologist.
Jabar. Yes, please,
Um,
ma'am.
yeah, it's very well explained and by Dr. Chetna Shamshery. Uh, Patient comes to us with sometimes with pain, with itching, with numbness, with tingling, and many a times they are having uh, abnormal sensations, and they explain in varied way. After 2 3 days of these symptoms, this having eruptions. uh, 40 to 50% of patients always applied on these different symptoms to different ointments, and they thought of this is a side effect of your local application. And when they come to us, they have small vesicles all over the dermatome. And we what we do, we start with either acyclovir, famciclovir, or uh, valcyclovir for 5 to 7 days. And if a patient is more than 50, we always start with small dose of steroid with the short course. That steroids work as an anti-inflammatory, as well as it reduces the pain as well. And if the pain is intense, we always give opioids for the pain reduction, because other modalities are not that very effective. Um, and we always try to prevent the post-herpetic neuralgia by giving this as soon as possible.
Okay, ma'am. Dr. Anurag, are you there? Dr. Sarita?
Dr. Shani, can I add few?
Dr. Sarita,
Yes,
can
ma'am.
you
Yes, ma'am. Ruchi ma'am, please add करिए.
Uh, say, like my experience with the PHN has been, then whenever there is a even very very bad PHN, but when there is a redness in the lesions. So whenever there is a redness in the lesions, the steroids along with the infiltration, local infiltration, subcutaneous, with it really really helps. Local anesthetic, steroid, and I add these two combinations. They subcutaneous infiltration helps a lot. Recently, I've noticed on the ultrasound that when you examine these patients, a lot of patients I've seen now, there is a the facial plane, that there is a contraction in the facial plane, thickening of the this facial plane.
band?
So even infiltration into the, I have done with a long needle into that facial plane, opening up that interfacial plane. So sometimes you beautifully see that the muscles which were contracted underneath this facial planes, they just open up beautifully, and there's a lot of pain relief in PHN. And the third thing which I have used is Botox. So Botox also, like, it is very helpful, especially when there is a allodynia component with it. Then I've infiltrated, in a smaller areas, in the intradermal areas. So it has been very helpful. So these are the few things which I have found it. So in the interfacial planes, even this local anesthetic, because the nerves pass through the interfacial plane to the dermis. So there it has been helpful. But initially, we have been doing it without ultrasound, just infiltrating otherwise. So that has been a very, very
At which stage you gave
beneficial. And like my residents and fellows, we have taught this technique, this simple technique. It has been very useful.
Yes, ma'am. I have listened your lecture on this topic in this conference. So first of all, thank you very much, Dr. Chetna, for presenting very nice lecture, very informative, and you have presented multiple cases with the management of the this problem. One thing I want to know, ma'am, lignocaine patch को आप यूज कर रहे हो lignocaine patch इसमें PHN में
Yes, we are using.
5%?
About me, you're asking me, Dr.
Yeah, ma'am.
No, I have not used the lignocaine patch. Actually, in UK, I saw Qutenza. They are using Qutenza for PHN. That was capsaicin, 8% capsaicin patches for PHN, and they would apply that Qutenza after applying a local anesthetic, and then they will apply a Qutenza patch over it. But that's not available in India. I haven't seen that. If that capsaicin 8% is available. So with local anesthetic patch, I have not used, but local infiltration is really, really useful. That is what I have seen.
Okay, thank you.
Yes,
Any other questions, Shivani?
Dr. Anurag, are you there? Or anyone who want to share their input, experience or nice case to be discussed?
Ma'am, I think Dr. Sujit is currently working on a few more cases of PHN with some new modalities. So if Sujit sir is there on the...
Dr. Sujit?
Yeah, hi, Dr. Shivani, how are you?
I'm fine. Any other inputs or how to manage these patients?
Yeah, sure, why not? First of all, congratulations, Dr. Sarita, for taking up the responsibilities of President ISPC. And under your leadership, now we have started this webinar series. So very nice to go about it. Congratulations. And Chetna, wonderful presentation. I'm sure all the listeners would have achieved so many practical tips. And regarding what Chetna was just shared, that for past some time we have been thinking of this PHN is a condition governed by both central and peripheral sensitization. So we target like central sensitization with this PRF lesioning, DRG PRF lesioning. And what I've been thinking, if we can have some alternative with the help of which we can target both the peripheral and central sensitization. So we are now, along with the PRF lesioning, we have combined with the interfacial plane hydrodissection with the 5% dextrose. Yes. And 5% dextrose has got a very important neuromodulatory phenomenon, neuromodulatory role, because essentially it's a neuroinflammatory condition. So it has got a very good neuromodulatory phenomenon which helps in reducing the pain. So we have done few cases, 3 or 4 cases, and we have been following these cases for a period of like 3 to 6 months and found interesting results. So now we are planning to work with this thing, that combining both the PRF with the hydrodissection, as Dr. Ruchi was also pointing out, with a different agent, that is 5% dextrose.
I've also done it with 5% dextrose. A few cases, they have given results, but not that much as with local anesthetic. I compared the two things. 5% had in some patients, they had a good result, not in all the patients. So when I compared it with local anesthetic, diluting it with 5%, the results were better.
So I have got some other, basically what I have seen, that I prefer not to dilute the 5% dextrose because the concentration is going to be diluted. But yes, as compared to local anesthetics, I have found that with local anesthetics I am finding a shorter term results as compared to the 5% dextrose. Maybe I am using both things combined with the PRF lesioning and 5% dextrose. So that might be one thing which is different as you are suggesting. That's all from my side.
Dr.
हाँ जी मैम,
Sir, any
wonderful discussion, you know, and congratulations, Dr. Sarita ma'am, for starting the new initiative. और बढ़िया डिस्कशन सब लोगों का हुआ। V1 वाले में क्या करते हैं, मतलब सॉरी आई एक्चुअली मिस्ड, आई जॉइन लेट। तो चेतना एक बार जरा सा प्लीज थोड़ा सा वो करोगे V1 वाले में जो।
हाँ सर, दिखाती हूँ सर।
तुम खाली वैसे बता दो
सर अभी तो जो V1 का केस किया है उसमें अगर रिफ्रैक्टरी हो जाता है तो इधर वी डू सुप्राऑर्बिटल सुप्राट्रॉक्लियर PRF। अगर ट्राइजेमिनल गैसेरियन गैंग्लियन लेने लायक पेशेंट है तो वो भी किया जा सकता है फॉर वी, नॉट एग्जैक्टली मतलब सिर्फ डायग्नोस्टिक पार्ट, बट सुप्राऑर्बिटल सुप्राट्रॉक्लियर PRF का भी रोल है। और जो मैंने केस शेयर किया था दैट वाज ऑफ बॉट्यूलिनम, क्योंकि बॉट्यूलिनम पर अभी सिस्टमैटिक रिव्यू भी आ गया है। मतलब मैंने तो वैसे यूज किया था बिकॉज आई सॉ कि वो रिफ्रैक्टरी न्यूरोपैथिक पेन है, इकोस्प्रिन पे है, कुछ और किया नहीं जा सकता है। तो रुचि मैम का जब न्यूरोपैथिक, सॉरी व्हेन आई सॉ द प्रेजेंटेशन ऑफ न्यूरोपैथिक पेन रुचि मैम वाला, सो आई ट्राइड ऑफ ट्राइंग दैट in that particular patient because the patient failed supraorbital supratrochlear PRF.
Okay.
And so then I had to switch on
नहीं
to
तो you use the
and it did
Botox
work.
in that sort of मतलब local
Yes.
infiltration that
Yes.
I'll again share sir. I'll again share sir. Basically, पूरा वही
preempt protocol.
theory था उसका.
Preempt protocol.
Yes. So this was the way I infiltrated. I basically marked
Yes.
about 1 centimeter gap, and
Yeah.
then 25 units in in small aliquots. Overall, a dose of 25 units I had given to this patient subcutaneously from the point she started having her pain till the point she was having her, and that was all subcutaneous. And so,
Okay.
like this particular systematic review also says that for PHN, a subcutaneous injection for PHN is something that may work. And then I
May.
showed the video also. So,
Great.
but this patient already had undergone a supraorbital, like the last line I mentioned. She had undergone PRF, she did not respond. So the last option that remained with me was botulinum. So I did try botulinum and she did have a relief.
Great. अच्छा इसमें क्या रिपीट करना पड़ा?
हाँ सर, वो आफ्टर 3 to 4 months एक्चुअली उसको जितना रिलीफ तो उसको 30 to 40% ही था, बट प्रोबेबली जितने एक्सपैंड विद द ड्यूरेशन दैट शी वाज सफरिंग फ्रॉम, शी गॉट दैट सोरेस. देयर आर 2 cases in which I have done one coming back to me every 3rd monthly. The other patient, she said abhi she visited about a week back to me with some other kind of pain, and then she was like really not willing to go for botulinum.
Okay.
She said that
she's
okay,
relieved.
not exactly 100% relief, but then
Yes,
कुछ
true.
हुआ होगा probably, she doesn't want it.
Great.
But then she was okay with bottle. I had a positive effect at least.
Yes.
Dr. Anurag, I have started doing one very interesting thing for all these trigeminal neuralgia or PHN patients on the face. I see it in under ultrasound. So if I find there is a contraction, small contraction, micro contractions or a major contractions, in those situations, Botox really helps. Because this fine, the muscles, the intradermal muscle, erector pili muscles, when they are contracting, and on ultrasound only you can appreciate this contraction, micro contractions. In these patients, it just works wonders. Not in every patient, as Dr. Chetna already said, there is no single thing which is used for all the patients. It doesn't apply to all. But particularly
how do you recognize those contractions, Dr. Ruchi?
Huh?
How do you recognize those contractions?
Sir, you keep it on the ultrasound. Then the muscular, if you see it, the muscles small, there is a contractions and there is a small fibrillation movement in the muscles. Erratic fibrillation movements. Erratic.
Okay.
They are not the normal ones. So they, you just keep it for a few seconds and you see the muscles contracting inside, the small muscles. And there is sometimes a shimmering kind of a texture which comes. So in these patients, it's very, very helpful.
Just like
but apart from PHN, also you shared your views related to
yes.
botulinum managing the other neuropathic conditions as well,
Yes.
if leave apart. So basically there probably it is the primary and the secondary sensitization or the neurogenic inflammation that it is covering, or in what sort of different cases have you used botulinum apart from PHN, ma'am?
I've used in neuropathic pains mainly, when there is a allodynia, and recently even in very severe neuralgia patients where there was a severe contraction of the muscles, abdominal. I have treated L1 neuralgia. So the patient L1, L2 neuralgia, so inguinal iliohypogastric area, there was a lot of contraction of the muscle when the patient was having pain, severe pain, and around 8 upon 10. So in these, I infiltrated the Botox. It was helpful.
And
Then there was another patient who had a backache patient, but if I would touch anywhere, she would show LTRs in other areas. So I discussed with Dr. Lakshmi also. So she told me to inject Botox, and it just worked wonders. Because my apprehension was that if I inject it in backache and the muscles relax, the strengthening of back will go down. But what I found, whenever there is a trigger zones, or there are LTRs, and they're injecting Botox 5 units, it's very helpful. So because otherwise, the patient is that those muscles are not useful to the patient in stabilizing the back. So LTR portions. So there when you inject, it's helpful.
Phantom limb pain or diabetic polyneuropathy is also you have used it?
No, I haven't used in those two conditions, not. But mainly whenever there is a erroneous activity of muscles, it's very, very helpful. LTRs.
मैम कितनी बार आपको बोटॉक्स देना पड़ा एक पीएचएन के पेशेंट में? जैसे अब चेतना का जो केस था उसमें तो बोटॉक्स ही लास्ट रेजिम था।
मैम ऐसा है कि इट वेरीज फ्रॉम 3 to 6 months. मेनी पेशेंट्स जहां पे बहुत ज्यादा सवेयर था उनमें 3 months लास्ट किया, और जिनमें थोड़ा सा माइल्डर फॉर्म था उनमें 6 months तक लास्ट किया पेन रिलीफ. It lasted till 6 months.
Okay.
Because otherwise, when we are injecting on the face for beauty treatments, people inject. So that lasts up to around 9 months. So some patients, it even lasts up to 1 year. But 9 months usually lasts. But in neuropathic painful conditions, it does not last more than 6 months.
Okay.
Even in dystonia patients. So I would say that when there are, these are ultrasound detected
Ma'am, one
is
question I would ask Dr. Ruchi ma'am. It's a known fact of tachyphylaxis with the repeated use of Botox. So
Yes,
what
sir.
has been your experience of the decreasing effect of the repeated Botox injections for these patients?
Sir, actually, I've seen it tachyphylaxis in one patient.
Only one patient.
One patient I found that after 2 doses, third dose it was not effective. That is only in one patient. I must have done in plenty of patients the Botox.
Okay.
But
So tachyphylaxis is not
definitely I
such a
found
big
tachyphylaxis.
problem. Okay. So that means that tachyphylaxis in reality is not such a big incidence as
No,
we
sir.
think.
No, sir. No, sir.
Okay.
So one thing more, I've maybe, sir, I'm not using single brand only. ये जो tachyphylaxis था ना, that was with the Allergan का Botox. So I've used different brands sometimes. Dysport is even better. So sometimes I like 2-3 sittings I do with the Dysport, then I change it over to Botox, because there is always botulinum. This is not all A. There are different botulinum subtypes, or different botulinum are there. So probably there is no cross sensitivity. I haven't found. Maybe it is there, but I haven't found it. One patient of Botox, particularly Allergan brand, I found that.
Okay. Great.
Nice.
Great.
I think so.
One
also
question
ask
more.
amongst the other participants if anybody has used any other modality apart from.
Good evening, ma'am. Myself, Dr. Neeraj from Yatharth Hospital, Great Noida. So I'm having currently treating a patient of herpes lesion. She had developed from past 20 days only at anterior chest and back at T2 to T4 level with type 2 diabetes. So can't use any sort of steroid. But is there any role of antiviral at this time at 20 days post lesion?
I think it works best if given within 72 hours of appearance of lesion. I don't know if dermatologist is yet with us. I think so. She must have left. So I think so. What I have read, it works best only till 72 hours of eruption of the maculopapular rash. If it is in the region of T2 to T4, I think so, with the subacute phase going on, because probably the rashes would have gone down now, and probably the drying up would have started. I think so. What should work best for you, according to literature, should be a thoracic epidural continuous, maybe for 4 to 5 days.
Currently, ma'am, her financial clearance are pending at it's a corporate hospital. So I'm managing her on pregabalin TDS with triptomar 25 HS with lignocaine patch 5% at the site of lesion for 12 hours on and 12 hours off. Then her VAS scores is now currently 4 by 10. Initially, they were 10 by 10, but still need to control the pain as it's a corporate patient, ma'am.
Yeah, so basically, if at all her finances they get arranged, so one condition, because her pain is still persisting, you don't want to get it converted into PHN. I think
Yes.
so. My best bet would be not a single shot procedure, but a continuous, multiple sitting procedure, and that has to be a thoracic epidural in this case, because that is actually possible.
Dr. Neeraj, in these patients who are very fresh, within 1 month, when their lesions are red, steroid, subcutaneous infiltration of steroid works wonders in these patients. And, like 2 sittings, 1 week apart.
Okay, ma'am.
Do 2 sittings 1 week apart, and you will find most of the patients, not all patients, but most of the patients, they are prevented from having PHN.
So what is that area, ma'am, around the redness?
Ma'am, I infiltrate only under the red areas.
Okay.
So the lesion may be huge, Lord. If I do mapping in every patient. So every patient is mapped. Whenever a patient of PHN comes, I do the mapping. And you will find that allodynia extends much wider than the lesions. There will be a much wider area of allodynia. So but the injection is always done under the redness, because these are the areas where inflammation is there, persisting. So once these inflammatory lesions go down, the allodynia area also reduces with time. Because allodynia with gabapentin, allodynia, mechanical allodynia and thermal allodynia, it's very, very helpful. So I add up gabapentin along with these infiltrations. Okay. It works wonders.
Okay. Or intercostal nerve.
Okay, thank you.
Sorry.
Ma'am,
Anything
the cutoff
I
drug.
can add in medications as procedure will be delayed by 4 to 5 days.
Which steroid drug dose? How do you?
So I inject Kenacort.
Dr. Shashank,
Usually, depending upon the lesion, how much lesion is there, because this lesions they are usually wider area, and you have to. I normally don't. I not go more than 40 units, but because I have to give in 2 sittings, 1 week apart. So I don't cross more than 40. But if the lesions are lesser, even I make it 20 diluted. 20 milligrams of Kenacort. So I dilute it with the local anesthetic 0.5% lignocaine, and that much. So I inject subcutaneously. I take a long spinal needle, and I go under the lesions, and just wherever there is a redness, I just keep on injecting and coming out. I don't inject and go. I reach there and I inject while coming out. So that's really, really helpful.
Ma'am, what about if at all the dermatologist is with us, the role of corticosteroids during this acute phase of 20 days that
It
that
doesn't.
some
It doesn't. It doesn't flare up, because I have seen the lesions, which were usually I don't inject in absolutely acute phase of like 10, 15 days. But sometimes pain is very severe, very, very severe. Then only I inject, but I have not found the flare up increasing with steroids. Somehow.
Ma'am, what about if Dr. Varsha can emphasize upon the oral usage of corticosteroids in this if the
I've
lesion
seen
is 20 days?
injection, subcutaneous injection works better than oral steroids, because
Okay.
whenever we get a patients, we don't get directly. They always come through dermatologist. And my daughter is a dermatologist, so she keeps on sending me patients from her practice. So that's how, like she's been in practice for last 10 years. So she keeps on sending me patients. So that's how I have, experienced. Initially also I used to do a lot of PHNs, but after her, I get lots.
And ma'am, again, the question that Dr. Dahiya asked about Dr. Varsha, are you there?
Yes.
Yeah, one of the person wanted to know if on 20th day of maculopapular rash he can give to his patient antivirals or corticosteroids in for other form apart from interventions.
After 10-15 days of vesicles or the eruptions, there's no use of antivirals. But definitely the oral steroids can prevent your post-herpetic neuralgia.
Okay.
She's a diabetic
Thank you.
patient actually. So I was restraining the oral corticosteroids.
Dr. Diya, when you use subcutaneous, no, the dose used is very low. It's,
Yeah.
when I get diabetic patients, I use it 10 milligrams.
Hmm.
I reduce the dose. 10 milligram of Kenacort does not
It
produce too much of changes in diabetic status.
only, ma'am, I was considering about oral that.
Oral,
Oral,
no,
yeah.
I haven't seen any much advantage of oral, because that only increases the sugars.
Yes, ma'am.
Your sugars get worse.
Yeah.
But subcutaneous, it is released slowly. There's a slow release, so the sugars don't rise that much versus oral steroids.
Thank you, ma'am.
Neeraj, are you using which patch are you using?
Sir, lignocaine patch 5%.
No, no, no.
Uh,
Which company patch?
Sir, I haven't say,
This
don't remember
what is the
exactly
size
which
of
company.
that patch?
Sir, 5 into 5 centimeter, I guess it is nearly 5 into 5
5
small
into
patch.
5 centimeters. So how are you able to covering the patch?
Sir,
Covering the area with the
Yeah.
patch?
sir, it's not covering completely, but a single patch at one time, alternate ways. First on chest initially, and later on back. Next visit.
Actually, if
Yes,
you
ma'am.
go through the literature, so
Yes.
this is the reason I am asking you this question, because there is a problematic thing which has come from the pharma companies actually.
Yes, sir.
The lignocaine patch or the Cutenza patch, which Dr. Ruchi Gupta was just informing about, 8%, they are supposed to cover the entire area of allodynia.
Yes.
And the current patch which you are using most likely is from one of our very close company, that is in TAS, and they have made it like a small patch,
Small
like
patch.
the diclofenac patch. So that is actually much less helpful than the other company patch, which is of big size.
Okay,
That
sir.
is like a plaster. So you are supposed to cover the entire area of allodynia. Then only you will get the complete benefit of this. Because this, remember, this is always a topical therapy.
Yes, sir.
It is working topically only on the TRPV1 receptor. चेतना will फिर से और
Yes,
receptor
sir.
बता देंगी. मुझे थोड़ा सा जो याद है TRPV1 और TRPV2 receptors पे. So it is working locally only. So the need to cover. So please try to find out that patch.
Okay.
Perhaps it was from Zydus or some other company. This is
Yes.
the big patch, and they are the only patch actually which can be cut. है ना,
Okay, sir.
20 से काट के उनको उस एरिया को
Okay, sir.
कवर करना है. तो अगर वो एरिया छोटा है और पैच बड़ा है तो यू कैन कट इनटू हाफ एंड देन यू कवर इट. तो एक पैच से तुम्हारा डबल एरिया कवर हो सकता है.
Yes, sir.
Getting my point?
Got
So
it, sir.
this is not like a stamp ticket type of patch. That is actually wrong preparation. They have made it and they are
It's very
marketing it.
small. Yes, sir.
And yeah.
That's the problem.
So
Probably
if
that
you
is the
try,
reason why I'm using this cream of combination, local anesthetic.
Dialogues.
Yeah,
yeah,
that
there are
is
multiple.
because then I have to use it three
Uh,
times. I can
Dr.
use
Anurag,
it. I can use it in an elaborate area, and so that is the reason why I'm not very much.
No, patch are very effective actually.
They are
Yes,
effective,
Lucknow
but
patches are
then
can.
they are
effective.
not cost
Yes.
effective actually.
They
But
are
now,
cost effective as well. If you use them, अगर वो बड़ा वाला मिल जाए, तो they are
yes, sir.
cost
your
effective. They are
class
very much
30.
effective, especially in the early, मतलब acute to subacute type of PH है. अगर बहुत पुराना 10 साल पुराना हो गया है तब तो कुछ नहीं काम करता, फिर तो
Nothing
अलग
works.
स्ट्रेटजी है, अलग स्ट्रेटजीज पे आपको जाना पड़ता है. बट
Hmm.
इन आवर हम्बल एक्सपीरियंस पैचेस वर्क वंडरफुली प्रोवाइडेड. 12 hour on 12 hour off is important and
Yes, sir.
coverage of whole area is important. तो थोड़ा
In
सा
this
बस यही
case,
मैं
sir, her back pain relieved, but chest pain persisted after 12 hours. That problem arised.
Hmm.
एक बार
Yes,
वैसा करके देखना.
yes, sir.
चलो भाई, थैंक यू. आई एम टेकिंग योर लीव. अभी एक दूसरा मीटिंग में थोड़ा सा मुझे एंगेजमेंट है. गुड विशेस. बाय बाय.
Bye. Bye. Thank you for coming, Dr. Anurag, joining. एक
There
चीज
is
और
a
पूछना था रुचि मैम कि
Yes.
ये जो बोटॉक्स का कितना इसका एक्सपेंस कितना पड़ता है?
Ma'am, Botox बहुत expensive पड़ जाता है. So
हाँ.
what we are doing is we are sharing it like that. We take a vial. We are giving them unit wise.
Okay.
क्योंकि एक जो वायल है वो अराउंड 20,000 की पड़ जाती है.
ओह,
तो इसकी जो डॉक्टर्स कॉस्ट है वो 18,000 है फॉर 100 यूनिट्स. सो उसके ऊपर चार्जेस लगाओ या कुछ भी, तो पर यूनिट वी गिव इट बिकॉज वी आर चैरिटेबल हॉस्पिटल. सो उस पे फिर आई डोंट चार्ज देम ओवर दैट, जस्ट charge them the units and the equipment, I mean the syringes and the gloves what they buy. So
it's costly
per unit
actually.
we are charging them, हमें practically 180 rupees per unit पड़ता है, and we charge 210 per unit. But in private clinic we charge 300 rupees per unit. But वहां पे डोज रिक्वायर्ड, जहां पे फिर डोज ज्यादा चाहिए तो we charge 210.
Okay.
Okay, Shah, any other queries?
If any other participant wants to ask anything, or shall we close the meeting if everyone permits? Any
Okay,
queries from any
thank you.
side?
I think there is no query.
Dr. Sarita, good night, everyone.
Good night.
It
Yeah,
was very nice lecture by
Chetna, it was a very nice,
very nice.
you
Thank you,
discussed
ma'am.
it very nicely. It was very nicely discussed.
Chetna Shamshery,
you
excellent.
in full spectrum of cases, from acute to subacute to chronic patients.
Yeah, very nicely covered the topic.
So thank you so much, everyone, especially Chetna ma'am, for delivering a very excellent lecture and giving beautiful insight in such a short span of time, covering all the topics, as ma'am said, the entire spectrum, and also all the experienced person who shared their insights, be it Ruchi ma'am, Shivani ma'am, Sarita ma'am, Anurag sir, Sujit sir, and Sanjay Dhira sir also spared his time. है ना? So I would be
अरे
thankful to all of you and all the participants for sparing their time to attend this
yeah,
webinar and making it a success.
it was a very nice presentation, and it was a very nice presentation and a very nice discussion too. And
Yes.
I am really like it was a knowledgeable experience for me also. And but just I wanted to ask if somebody has given the cognitive behavior therapy here also. So would anyone share if at all CBT was used in any patient before in these patients, or whether it helps or in neuropathic pain management of these patients? Because in this is not my area of forte basically. Neuropathic pain we have been managing in cancer patients, in which some of counseling is given to the patients. So in these patients, do they need counseling? Because DN4 is like more than 14 and something, it's a high score. So does CBT help in these patients, or it is of limited value, or should we start using it, or
The literature says CBT helps in these patients. All neuropathic patients में CBT help करता है.
The literature says, but practically nobody does CBT. Practically, we don't have those specialists who do CBT.
Who are doing it?
Like abroad, there are people who are specialists in doing CBTs. So it is said it's very useful. You will find all the papers on neuropathic pain that it is helpful. But practically, I've never seen in so many years anybody doing CBT.
Okay.
Somebody may have an experience, but I have not seen anybody doing it.
No, I also don't like. We are counseling the patient, but going through CBT, I was thinking that if anybody has any experience of that, so that is one thing we can build upon, or we can have a networking or something like that, so that CBT is also done, so that we can in the Indian scenario context, we can have some literature of it. Like we are having some literature on Botox now, and we are having some literature on capsaicin now, and we are having a much of literature on the blocks, but we aren't having any solid literature in the Indian context on CBT on neuropathic patients, or these type of patients. So we can build a networking with.
India में rehab people ही नहीं है. बहुत ही rarely you will find rehab people, especially in tier 2 cities where we work. We don't have. मतलब मेरे को I don't think. पंजाब में मुझे एक भी वो पता rehab person पता है जो कि who's doing it.
CBT दे रहा है.
Yes. But when I went to UK, you know, there are specialists there sitting. So there was. They do things.
Thank you, madam. Thanks a lot. Congratulations, Sarita. तुमको congratulations मैं बोलना भूल गया. हाँ.
Thank you, sir. Thank you for joining.
Congratulations, Dr. Sarita.
For blessings. आप लोगों की जरूरत है इसमें.
और चेतना बहुत बढ़िया लेक्चर था यार तुम्हारा, बहुत बढ़िया था, और डिस्कशन भी बहुत ही हेल्दी हुआ, बहुत अच्छा डिस्कशन हुआ एक्चुअली.
Thank you, sir.
चल बढ़िया.
Bye, sir.
Thank you.
Thank you
everyone.
Thank you everyone.
Good night.
Thank you. Good night, everyone.